So welcome everyone. Thank you for joining to our PGT-A webinar with Dr. Sami and Karen. So as you may know, Dr. Sami is our doctor. He's a lead doctor from Blind New Baby. And Karen, she is our genetic counselor. So we will be answering you all the questions that you may have related to PGT-A. So Karen is going to do a presentation first, and then there will be a space for you to do all your questions to the specialist. So Karen, please feel free to start, okay?
Good evening, everybody. I'm going to talk to you about preimplantation genetic testing for aneuploidy. And what you're seeing before I go into the seminar or webinar, I just want to explain to you what you're looking at in terms of this photograph that's on the screen. Because every time you look, if you're searching for anything about PGT-A, this photograph or an image comes up, and it's kind of interesting to know exactly what you're looking at. In the center is an embryo, and at the left-hand side is it's a little instrument which is holding the embryo in position. The embryo is in a little dish. And then on the right-hand side, there's a tiny micropipette. And what that's doing, you can just see it's sucking a few tiny little cells from the outer layer of the embryo. And it's those little cells that are in the micropipette that we're actually going to be testing. So the embryo itself gets frozen and stays in the clinic, but it's this little sample that's actually tested when we're looking at aneuploidy. So what is PGT-A? It's basically, we're screening the embryos for the number of chromosomes that are in that sample. It's an add-on to IVF treatment, so it's not standard practice. It just sometimes, this PGT-A can help a certain group of patients. The point of PGT-A is to help select embryos that have the correct chromosome number that will improve the chance of pregnancy. So that's it in a nutshell, counting chromosomes from a little tiny sample we've taken from an embryo. So the big question then is, well, why do we do that? You know, why do chromosomes matter? And we're going back to real basic biology. We as humans have 46 chromosomes, which exist in 23 pairs. We get a half a set from the egg, we get the other half from the sperm, and that in the very first cell of an embryo forms the complete genetic makeup. 46. And all aneuploidy means, it's a strange word, all it means is when we have the incorrect number of chromosomes. So we don't have 46, we have more than 46, or we have less than 46. And the classic example that most people know is Down syndrome. So Down syndrome is caused by an extra copy of one chromosome. So instead of 46 now, we have 47, and that particular extra copy is chromosome 21. And that 3 copies of chromosome 21 is often referred to as trisomy 21, or in the old term, Down syndrome. There's another example on the screen here. One of them is Turner syndrome, and that's when we don't have 46 chromosomes, we have 45, and we have a missing copy of chromosome X. So this affects females. And then another example we put up there is trisomy 22. So 3 copies of trisomy 22. If an embryo has 3 copies of chromosome 22, it's incompatible with life, and it always leads to miscarriage. So this is really why chromosomes matter in this very early stages of conception. If an embryo has too many or too few chromosomes, it can result in a number of things. One of them is a failure to conceive. So in other words, we just have too many chromosomes and we're not conceiving, or too few, actually. And the embryo is created but doesn't implant. Or the embryo may implant and then it may lead to a miscarriage, an early miscarriage, usually in the first trimester, the first 12 weeks of a pregnancy. The classic one I've just explained or described is trisomy 22. Or it could lead, and this is rare, but it could lead to a viable pregnancy which is affected by a chromosome disorder. And the 2 chromosome disorders I've just pointed out are Down syndrome and Turner syndrome. So they're pretty important in early conception. So the next question is, well, where does it come from and why does it come? So it's mostly sporadic. Most of the time it's sporadic, out of the blue. And it usually comes, it's either coming from the egg or the sperm So when an egg matures, it has actually the egg and the sperm, when they mature, they have the full set of chromosomes, but they undergo a maturation process leading to half the amount, so that we end up with the 23 coming together, fusing together to form the first cell of the embryo with 46. But as an egg ages, or the eggs age, they age with females, then often there's a little breakdown in this maturation process, and that can lead to extra copies or missing copies of chromosome. So it's strongly associated, aneuploidy is strongly associated with what we call advancing maternal age, but actually it's the egg age, it's the age of the egg, which is the same age as the female at the time of conception. It can be seen in sperm, but it's pretty unusual to see it in the sperm. So it's associated with advanced, as we call it, advanced maternal age. What we're showing on the screen there is just an image really to show egg sperm and the production of that first cell, not completely accurate. And then there's this it's called an ideogram, it's a diagram showing the sets of chromosomes in pairs. And what we've got there, we put there's 22 matched pairs. They've got a very definite banding structure. Chromosome 1 is the largest in the set, 22 is the smallest. That banding pattern, I often describe them as little barcodes, and we can just see that all the genetic material is in the right place when we do a chromosome analysis. 22 matched pairs, these are called the autosomes, and then we've got the sex chromosomes. Females have 2 X's, and males have an X and a Y chromosome, single. So if we do PGT-A and we do this analysis on that tiny little sample we've taken from the embryo, what can we find in that sample? Well, obviously, we can find missing or extra chromosomes, which is the whole point of doing PGT-A. But the testing that we use is very sensitive, and we can actually find that we've got missing sections of chromosomes. And that can be quite important, because often these little missing sections, depending on the size, could lead to usually miscarriage, but could lead to a genetic disorder. The common aneuploidies we can find, I've just mentioned the trisomy 21. The common 3 aneuploidies, the trisomy 3 copies of 21, trisomy 18, 3 copies of chromosome 18, and trisomy 13, 3 copies of chromosome 13. It's sensitive enough, actually, the testing now, to detect triploidy. And all triploidy means is that we've got 23 chromosomes from one of either the sperm or the egg, and we've got 46 chromosomes from the sperm or egg, leading to a count of 69. So we now have too much, 3 copies instead of 2 copies. So that we can detect. It's very rare, but it's possible to see that in that biopsy sample from the embryo. Polyploidy means we may have more than 3 copies. We might have 4 copies of these chromosomes. Again, that's even rarer, but it's possible to detect. And as you've just seen from that little diagram that I had up of the chromosomes, we can, if the country of origin supports this, we can actually detect, we can report on gender. So we can tell you if the embryo is female or male. And then there's a little kind of, it's an extra little bit of chromosome testing or PGT-A. Sometimes we can detect the parental origin of aneuploidy. Now, in order to do that, we may need DNA from the biological parents, and we can then do some testing to find out, is this aneuploidy that we're seeing in the embryo, is this egg related or is it sperm related? So for some couples, that might be an important test at a certain stage of their cycles or their treatment. So who might consider PGT-A? Well, there's been lots of different, there's a lot of discussion about this, and has been actually for the last 20, 30, 25 years since PGT-A has been in use. But the consensus now is that women, usually over the age of 35, may benefit if they're struggling to conceive. And the recent data is saying women from 37 upwards could consider having PGT-A as an add-on to their IVF cycle. Why would they add it on? Well, if they've had previous failed IVF treatment and the embryos that they've transferred have not resulted in a pregnancy, or they've resulted in a pregnancy and they've had a miscarriage. The other option is recurrent pregnancy loss. So some couples will, or some women will experience recurrent pregnancy loss, and it may be beneficial to consider PGT-A at that point. Severe male factor, sometimes that can, PGT-A can help if the suspicion is that there is something in the production of the sperm that's leading to an aneuploid, leading to some form of aneuploidy. It's not the most used. I mean, I really would focus on the women and the recurrent pregnancy loss and previous failed IVF. There's another option that sometimes people consider PGT-A when they're choosing to do single embryo transfers. So some clinics will do double embryo transfers. It depends on age of the patient, and Dr. Sami can talk a little bit about that, I'm sure, later. And I know, and when you get over 40, sometimes you're choosing 3 embryos to transfer. That's so specific in the UK. But if you want to just focus on choosing a single embryo, and embryos you haven't got many embryos, it might be beneficial to look at the chromosome complement at that embryo. And more often, actually, I'm seeing patients who have frozen embryos in storage. They've had failed transfers, and now they're considering, why is this happening? And we have no reason. Everything else is all been fine, and it may be the age, it may be this previous failed IVF, and then some patients may consider, okay, let's thaw these embryos, let's biopsy them, refreeze them, and then send them for analysis. So there's quite it's quite nuanced actually to do that, but there's some data supporting that this can help patients who have previously failed transfers. This is just a kind of the process of the PGT-A and at what stage we do this. But essentially, we need to have eggs and sperm collected in an IVF clinic. Then the eggs need to be fertilized, and that can be done in 2 ways: with ICSI, injecting 1 sperm into the egg, or with IVF. The embryos then grow for 5 to 6 days. So they become, the very first image I showed you, the photograph, that's an embryo at day 5. And it's that point, it's called a blastocyst. And it's then when we can do the biopsy to take a tiny little sample, and estimated between 5 to 10 cells are taken from that embryo, sent off to the lab for biopsy, and the embryo is frozen in the clinic waiting for the results. So in terms of benefits, well, data supporting that there is a higher chance of pregnancy because we're transferring genetically competent embryos. I'm going to use another word, I haven't put it on the slide, but euploid embryos. And all euploid means, it's the opposite of aneuploid, it means we have the correct number of chromosomes, i.e. 46. As a result of that, there's a chance that embryo will implant and lower miscarriage risk. Support single embryo, we mentioned that previously. And there's data to support that it may reduce the number of IVF cycles needed in order to have a child, in order to have a baby. And that's because we're decreasing the time by just transferring embryos that are genetically, I'm calling them genetically competent, but let's go use the other word and use the euploid. So they're the benefits that we can see. There are limitations of the PGT-A. And one of them is, it's not 100% accurate. I mean, no test is 100% accurate. But when you visualize that little embryo and the tiny sample we're taking from it, then there is a chance we're only checking that sample. And the inference is that the rest of the embryo is the same chromosome number. So the misdiagnosis rate, it varies between labs, but it's quoted as around about 98%. So 98% accurate rather, and misdiagnosis rate between 1% and 2%. So it's just a possibility that it may not be truly accurate. There's also, I've put it on the slide here, I'm not talking about it this evening, but there's also a chance that we may get a result which is ambiguous in terms of the number of chromosomes, and it's called mosaicism. And what we can find in that sample is that some of the cells are giving a euploid reading, a signal, and some of the cells are giving a signal which says there's an extra copy of chromosome or a missing copy. And that means we've got 2 cell lines and we need to interpret that very carefully about whether we transfer the embryo or not. It's only, the other limitation is it's really testing for these chromosome abnormalities, single chromosomes, or these segments I talked about earlier. These are large chromosome abnormalities. It's unable to detect the very small chromosome deletions or duplications. So these are ones that can potentially lead to a child with genetic condition. It doesn't look for single gene disorders, so we're not going down to the gene level. It's really quite a high-level test. And it doesn't find structural rearrangements, which can be inherited. So it's not looking for anything that's inherited in the genetic makeup. And then it put an extra copy in there, about an extra sentence in there about multifactorial conditions. And these are the conditions where we have genetics and the environment, and we don't really kind of understand how they interact. And a kind of classic example of a multifactorial condition is type 2 diabetes or certain cardiac risks as we get older. So what do you need to consider if you're thinking about putting PGT-A or adding this to your cycle? The main thing is that there may be fewer embryos available for transfer. So if you think about, we have a patient who is 37 years old, we have 10 embryos available to test. That would be a fantastic result, by the way. When we look at the PGT-A results, then we might find that a cohort, quite a large section of those embryos are not available because they would be aneuploid. So that it reduces the number of embryos available for transfer. There's also, it's quite, adding PGT-A, usually patients have gone through failed cycles or miscarriages, so there is an emotional aspect to this, to considering PGT-A, and also a financial cost. So it's quite nuanced, and it depends really on the patient and the couple who are considering this as part of their treatment. In terms of biopsy, cryopreservation, and thaw, I've put risk. It sounds like it's a big word to put in context, in this context. But obviously, the embryologists are really competent. They will only biopsy embryos that are going to survive a biopsy. So you have to be a certain grade. And that's also related to the cryopreservation. So that only certain grade embryos are frozen, so they've got a good chance of thawing. But there is always a risk of loss of an embryo, even without PGT-A. So that's a possibility that needs to be factored in. That becomes more obvious when we do PGT-A on the frozen IVF embryos, because obviously we're freezing an embryo in the first instance, we're thawing the embryo, taking the biopsy, refreezing, testing, and then thawing again for transfer. But there is data, good data now, on that this can be there's a successful and positive outcome for patients. But with everything, of course, with IVF, there's no guarantee that it's going to result in a pregnancy, ongoing pregnancy, and a live birth. And it's hopefully it does, and that's why we're considering that. So it's really quite important to basically ask your doctor, is this the right thing for me or for us? What would I do if all the embryos come back as aneuploid? What are your options after that? How long will it take? That's another question. It's usually, because we're just doing this test at the end of, it's pretty much 2-week turnaround for results. So, but it depends on where you are in your IVF journey. And of course, importantly, how much was this cost? And then the big question is, what do we do with transfer of a mosaic embryo? Is that supported in your clinic? And is there help, i.e. from someone like me, who can discuss those results with you? So I hope I've given you some overview, actually, of PGT-A, where it fits in an IVF cycle, and the sort of things that we can test for. So now I'm going to hand over to Dr. Sami.
Thank you very much, Karen. That was really, really good. And
thank you.
Very clear, covering quite a complex subject, I know, but hopefully our patients will be able to grasp a lot of what you said. So thanks for that.
Pleasure.
So I'm just going to go through kind of a little bit more towards the clinical side of things. So we've talked about the PGT-A itself, but in order to do PGT-A, we of course need to obtain embryos. So the first step is to stimulate the ovaries to get eggs. Normally in a menstrual cycle, a woman is going to produce just one egg, but we would ideally like to get more than that so that we have hopefully more embryos that we can then check. So the stimulation is IVF stimulation. So the woman would take for approximately 2 weeks the hormone medication, injections, and then we will also do monitoring. So we'll need to do ultrasound scans and blood tests to make sure that this treatment is given in a tailored manner without giving too much of the medication or too little of the medication, because that can also affect the safety of the cycle. The woman may overstimulate and become unwell if we give too much. If we give too little, we don't get as many embryos, and even giving the wrong amount or wrong type of drug could perhaps even affect the egg quality. The eggs are then collected in a small procedure. So this procedure is done under anesthetic, and a needle is passed through the vagina into the ovary to aspirate the fluid which will contain the eggs. And then we would need, of course, sperm, usually for the partner, and he will need to give a sample that day, or sometimes we have frozen sperm that we can use. And the sperm will be used to fertilize the embryo. In the past, I remember certainly when we first started doing PGT-A, we had to do an additional step called ICSI, where we inject the sperm inside the egg. The belief was that would reduce contamination, but nowadays we don't actually need to do that. We can do conventional IVF. If the man's sperm is good sperm, then that's a good thing that we can do now, even with PGT-A, just conventional IVF. Next day, we see how many of these eggs are fertilized. Typically, we get 70 to 80% of the eggs to fertilize, and then we need to leave the embryos to develop for a few days in the laboratory. Usually, the embryo will be biopsied on day 5, 6, or sometimes nowadays even day 7, which is what we call the blaster stage. And not all embryos are going to make it that far. So we will lose some embryos as we go along. And yeah, if you get 10 eggs, you may end up with 2, 3, 4 embryos. Depends a lot on your age and egg quality and things like that. Next slide, please. This is just to show how stimulation works in IVF with Plan Your Baby. So we would always like to check with a scan and a blood test on the first or second day of the period to make sure that everything is in good shape for us to begin, because every cycle is different. And if it doesn't look like a good cycle to do the IVF, if the hormones are not quite right, if there's cysts on the ovaries, then it may be better to skip that month and try it for another cycle. Then the stimulation injections will start, which will be taken by the woman herself. She will inject herself. She'll be taught how to do that. And typically the injections are taken for between 10 to 16 days, which will then involve alternate daily blood tests, alternate daily scans, and then in the last day or two, we might even need to do daily blood tests as the lady becomes closer to her trigger injection, which is the final injection to mature the egg. And all the medication instructions are given on the basis of the results. So when we see the results, tell you which medication to use, how much, so that we can tailor very carefully the drugs. And this is just a diagram to show you how the egg collection works. So it's a simplified diagram, I know, but it gives you an idea. So using a transvaginal ultrasound probe, the needle is then passed through a needle guide directly into the ovary. There isn't all this space, like you see on the diagram. The ovary is pushed straight onto the probe, so there's very little space in between. And the follicles, which are the big circular fluid-filled sacs in the ovary, are drained, and this fluid is then checked by the embryologist, and any egg is then removed for use later on to fertilize. It does come with a small risk. So the risk is small for bleeding, infection, injury to bowel, bladder, or blood vessels. It's about 1 in 1,000 risk. And yeah, I mentioned quickly about IVF and ICSI earlier. So IVF is where we just put the sperm around the egg in addition, allow it to fertilize by itself. And we do that when the sperm is good, or we know that there's been good fertilization, or the man has had children before, naturally. But if the sperm that we're dealing with is suboptimal, if we're having frozen eggs, if the sperm is directly obtained from the testicle, or sometimes when we're dealing with infectious diseases such as HIV, then we may choose to inject the sperm inside the egg directly, and that's called ICSI. So we select the best looking sperm, and 1 sperm is injected into each egg. Next slide. So this is just a little bit of the timeline. I know Karen's gone through this already, but yeah, so once we have the fertilization of the egg, we make the embryo, and the embryos will be tested on day 5 or 6 or sometimes 7. Because it takes around 2 weeks to get the genetic testing results for the PGT-A, we need to freeze the embryos. Now, Who knows, maybe in the future we won't need to do this if the technology advances, if we're able to do it. I mean, theoretically, we could be able to do it quicker, and we can then do a fresh transfer, but currently we are still limited by this, and we need to freeze the embryo to wait for the results. Then we review the results. If there are embryos which are good that we can transfer, then we would arrange for a frozen embryo transfer cycle. So that's a completely new treatment cycle where we prepare the woman's uterus to receive an embryo, and there will still be some need for blood tests and scans and quite often medication to support that. And then the embryo is transferred. Following this, we can do a pregnancy test and hopefully monitor that pregnancy and eventually have a live birth. So, of course, like everything, there are pros and cons, and the biggest pro is that it does reduce miscarriage rate, and this is the main draw for people who have recurrent miscarriage, especially, is it can reduce miscarriage rates that are down to miscarriages from chromosome defects. Of course, there are different reasons for miscarriage, but if it's an older woman, then it's more likely to be chromosomal, or if we know that the woman's had lots of embryos which have been tested genetically after the miscarriage and found to be genetically abnormal, then this could be a way to reduce that. Similarly, it will reduce the risk of chromosome abnormalities that can lead to syndromes and diseases like Down syndrome, Edwards syndrome, Patau syndrome. These are all linked to the number of chromosomes being abnormal. This will reduce it. And sometimes it will reduce the time to being successful having a baby. For example, if someone has 10 embryos in a cycle and we can only transfer 1, 2, or maximum 3, depending on the age, and we don't know just by looking at the embryo from the outside which of these embryos is genetically good or not, because yes, there is a grading system that we have, but actually it doesn't link very closely to the genetic makeup. And we can think that this embryo is a better embryo when in fact the genetics are abnormal. And I've seen it many times where the poorer quality embryo is the one that has the good genetics, and that's the one that leads to the live birth. So this way we can reduce the number of cycles this woman has to go through to be able to get pregnant. However, it may prolong it as well, because let's say, for example, we only get 2 embryos. We have to then freeze these embryos to wait for the result. Then we go through a new preparation cycle. So we're extending the whole time for her to be able to get that embryo transferred if she has a genetically good embryo, rather than reducing time. So it depends, I think, on the scenario. Now, the disadvantages, first of all, not all embryos make it to the blastocyst stage. So if we are in a situation typically where we have someone who's only producing 1 or 2 embryos and we're not planning to test the embryo, then usually we transfer the embryos earlier, usually around day 3 or sometimes even day 2, because the best place for the embryo to develop is not in the laboratory, but actually inside the natural environment in the womb. And if we don't need to select embryos because we have the embryos which are going to go back, then that is the best place for us to develop them. So in the lab, it may be that we may lose some embryos trying to get them to the blastocyst stage. Also, we said that the embryo has to go through biopsy, so we have to remove 5 to 8 cells from each embryo. We have to freeze the embryo. Later on, we have to thaw the embryo. Each of these are stressful for the embryo slightly. We always, in the lab, try and minimize the manipulation of the embryos because they are very delicate structures. And this manipulation may slightly lower pregnancy rates. It may slightly weaken the embryo. Another disadvantage, we have to go through 2 treatment cycles before we can get to the transfer, a fresh stimulation to make the embryo, and then a frozen embryo replacement cycle. Test is quite expensive, so it depends on how many embryos you get, but it can add on a couple of thousand or more to your IVF cost, which in itself is not cheap. And Karen's already mentioned it's not 100% accurate. There is a small error possibility, and I have seen actually that happen before, where embryo was labeled as normal and eventually that poor woman miscarried and it was tested and found to be genetically abnormal. So there was an error with the result. And also another thing which is important to bear in mind, again, we've mentioned this in Karen's presentation, is the mosaicism. Mosaic embryos mean some of the embryo cells were tested and found to be normal and some were found to have abnormality. And this is a difficult situation. In the past, 8-9 years ago, we used to throw away these embryos. We didn't transfer them at all. But there have been lots of cases where people have had these embryos transferred and had healthy babies. We can still use them. We would recommend that you have genetic counselling with someone like Karen or Valerie, who's our other genetic counsellor, to go through the implications of using such an embryo, because it does have lower chance for pregnancy and higher risk of miscarriage compared to the genetically normal euploid embryo. But they are still embryos that we can use. So yes, it's not a black and white test. There is this grey area that we sometimes face, which can add to the confusion, and sometimes patients find it quite distressful actually, that they weren't fully aware that this could be an outcome, that the embryo could be mosaic. So it's important to understand this from the start. Next slide, please. So yes, I mean, I think personally the best people to consider PGT-A are people who have recurrent miscarriage, especially if we know that there's a chromosome defect which is causing it. The reduction in miscarriage rate is the primary goal here. Or if we do get patients who are older than 37 years older and they have a good egg reserve, so we're expecting to get hopefully multiple embryos and maybe excess embryos, then it may be a good situation where we can reduce the number of transfers and also possibly reduce miscarriage rate. So these are my favorite patients to do the PGT-A. I mean, there are other scenarios as well, but these are kind of the two main ones I think that should consider it. Okay, thank you for that. If you can stop sharing now, Karen, please. And I think we've got some questions, Vivian.
Yeah, well, first of all, thank you, Sarah and Dr. Sami, for sharing your expertise on PGT-A and IVF. That was truly insightful, and I'm sure that our audience found it very helpful. So we're going to jump into the question and go at the top because we have a few. So Joe is asking, can anti-sperm antibodies affect the sperm quality and chromosome numbers?
So anti-sperm antibodies are antibodies against sperm itself, and they can have an impact on fertility. What they can do is they can clump the sperm together, agglutination we call it, and make it difficult for that sperm to move, so it affects the motility, and they can even stop them from moving altogether. They can also interfere with the ability of the sperm to penetrate cervical mucus, to bind with the egg, fertilize the egg, and sometimes if it's very severe, the antibody can even destroy the sperm once it's inside the female reproductive tract. So they definitely have an impact on fertility, especially when we're talking about trying naturally or doing things like IUI treatment, etc. But they do not have an impact on the genetic makeup of the sperm. That's not going to be impacted. The DNA is not affected by these antibodies at all.
Okay, thank you, Dr. Sami. I think that this question is more for Karen, but you let me know. They're asking, we are cousins. Will this help?
There's no relevance between being related as cousins to whether you've got aneuploidy in embryos. Right at the beginning, I said it was sporadic, just by chance that it arises. So yeah, it doesn't affect the chromosomes in terms of conception.
Okay, well, thank you very much, Karen. So next question for Dr. Sami. What if the women have low AMH level but don't want to use an egg donor?
Yes, I mean, this is not completely linked to this topic, but I'll still answer this woman's question. So the low AMH means that this woman's got a low egg reserve, and it doesn't actually stop you if you have a low AMH from conceiving even naturally. So it's not always a cause for not conceiving naturally. It can, if your AMH, if your egg reserve drops to the extent where you're not ovulating anymore. So if you're not getting regular periods, then maybe, but most of the time that's not what we see. But if you have a low egg reserve, then it makes it a challenge when we're doing IVF to get multiple eggs, because that's what we ideally would want, is to get multiple eggs, because then we have more chance of getting embryos and more embryos to select from, and therefore overall the success rate of the IVF would improve. But it doesn't mean that a woman with low AMH cannot try IVF as long as her egg reserve is such that we can still stimulate. So, there's a spectrum to this, of course. And if we're talking the extremes, then yes, maybe egg donation is the only option. But that's not what we see for most people. And there are further tests that we do in addition to AMH. So we do a hormone profile at the beginning of the woman's cycle. And we can also use the ultrasound scan, appearance of the ovaries, to judge this, and we can still try stimulation. Usually if the AMH is very low, we may go for a gentler stimulation, something like a modified natural cycle, where we only give a small dose of medication. Typically we get 1 or 2 eggs with that, but even if we were to give the high medication in such cases, we would only get 1 or 2 eggs anyway. So there are still options for treatment, but it definitely does depend on how bad the drop in ovarian reserve is, and if it's an extreme level, if it's perimenopause or menopausal. Unfortunately, there are times where we can't help even with medication.
Thank you, Dr. Sami. So this lady, she was asking about clinics abroad, but just letting you know that we can do PGT-A in the UK, so you don't have to travel abroad, so we cannot advise on that one. But the second part of his question, is, will you say that genetic abnormalities usually lead to earlier miscarriages, or are they still just as likely to cause miscarriages around 8 or 9 weeks?
Well, genetic abnormalities is a big term. What we're talking about is, we're talking about a missing chromosome or an extra chromosome. And generally speaking, a missing chromosome, if we see that, it's not a viable pregnancy, and they often don't implant. The only exception to that is Turner syndrome, where we have one X chromosome. So we've got 45 chromosomes. I mentioned it in one of the slides. But if there's an extra copy of a chromosome, and that classic one is 22, then that will lead generally to a miscarriage. It's not viable, it's not compatible with life. The other one that's also associated with early miscarriage is chromosome 16, 3 copies of that. And we can see that the embryo, but actually where we see it and why we understand that this is not compatible and will lead to a miscarriage is in prenatal testing, where the products of conception are analysed, and that's where we find the extra 22 or the extra 16. So what we're trying to do with PGT-A is see those embryos and then not transfer them, because it's just got a high risk of miscarriage.
Thank you, Karen. I think that kind of answered the next question for Jenny, because she was asking, if an embryo is not suitable for testing, will you transfer it instead?
Can I just add to that comment as well, that the question I get asked a lot is, can we know the cause of miscarriage based on when it happens, how many weeks? So someone says, my miscarriage is always 5 weeks or 8 weeks or 10 weeks. Does that tell us when it happens, what the cause of miscarriage was? And the answer, unfortunately, is no. It can still be any of the cause of early miscarriage. Now, when we group miscarriages, usually we group them as early miscarriage, which is the most common by far, and late miscarriage. Early miscarriage means within the first trimester, within the first 12 weeks. And the most common cause is chromosome abnormality, but there can be other causes to do with clotting, immunology, hormonal, uterine, etc. And then the late miscarriages, most of the time, those are either linked to the cervix, weakness of the cervix, or uterine abnormalities, things like that, or infections sometimes. So we're talking mostly here about the early miscarriage within the first trimester. And even with chromosome abnormality, you can get sometimes the embryo is just not going to implant because it's abnormal and the body rejects it. Sometimes it will implant, but it will miscarry within the first week or so after a positive pregnancy test. And sometimes I've seen it where it goes all the way up to screening tests at 12 and 13 weeks. And we know that this can happen with embryos, especially, that's why we do things like down screening, etc. At around 12 weeks to check for these things. So the embryo can actually keep progressing even if there is a chromosome abnormality. Question that she asked Jenny about if the embryo is not suitable for testing. Depends also what you mean, what not suitable. So if it's not suitable for testing, it may not even be suitable for transferring or freezing. And if that's such an embryo that we have, then no, we won't transfer an embryo when it's too poor quality, because that's not going to be helpful. If the embryo is not, sometimes what we get is we get an embryo which is tested. And another thing which we haven't mentioned, it's not common, but you can get an inconclusive answer. So we don't know is basically what we get, and that's a very frustrating situation, because you've paid money, you've done this procedure, and the answer is we don't know. We can still transfer the embryo if you wish, because it's the inconclusive answer, and we will keep such an embryo. But if the embryo is not suitable for testing, usually that means it's not a good grade embryo that we can keep or transfer or freeze or anything like that.
Oh, I have another question for Dr. Sami. Do you do abdominal egg collection? Well, more into clinical side. Do you do abdominal egg collection as a fibroid may be stopping the way to one of the ovaries vaginally?
This is sometimes a challenge for women who have big fibroids, is that they can obstruct our pathway to the ovary and make it very difficult to reach the ovary. Now, when the woman is asleep, we will try our best. We'll push down sometimes on her tummy, we'll push quite hard through the vagina to try and reach that ovary, but sometimes it's just not possible. So another way that can be tried to collect the eggs is going straight through the abdomen. Now, it's not possible in every situation, because there may be another fibroid, or the fibroid may still be blocking the way abdominally. So not all ovaries are accessible, unfortunately, and that's something which should be assessed prior to starting the IVF. But there are situations where the ovary may be much more accessible abdominally. It may just be sitting under the skin. In fact, I've seen that quite a few times. You probably have as well, Vivian, when we've done egg collections together. You can just go through the skin quite easily, much safer than going through the vagina in that situation. But not all clinicians have experience with this, I know. So it's something that we would kind of need to prepare for in advance of starting the IVF. But it may be an option. It's not always an option, though.
What about women with cerclage?
Well, you can do collection with cerclage. That's not going to interfere with cerclage, but the cerclage can interfere sometimes with the transfer. It's rare. So the cerclage basically is where, and this woman I expect is talking about abdominal cerclage, where they have had preterm rupture of membranes, or they've had late miscarriages where the cervix opened up too early, 17, 18, 20 weeks before the age of viability, and they've lost their baby for that reason. What can be done is they can have a procedure pre-pregnancy where they go through the tummy and they will put a permanent stitch into the top of the cervix to kind of tighten it and support it. Now the stitch isn't so tight because this woman needs to menstruate. She still needs to pass that blood, and also you want the sperm to be able to get in so that she can have a pregnancy naturally, hopefully. So it's not that they are sealing off completely the two areas, but it can be quite tight sometimes, and it can make it difficult to transfer the embryo, because when we transfer the embryo, there's a very fine, soft plastic tube which needs to pass into the uterus. So in a woman with a cerclage, especially an abdominal cerclage, it's probably a good idea to test this beforehand with what we call a mock transfer or a dummy transfer, where we just bring the woman into the clinic and pass the tube that we use, an empty tube, and see if it goes in easily. Then we're fine. And most of the time it does. Most of the time it's not an issue.
Okay, thank you, Dr. Sami. So for Jenny, I know that you're asking about the blood-stimulating stimulation. I mean, all clinics have different protocols. So here with Plan Your Baby and Dr. Sami, we do blood scans every other day, and we will be testing your hormones, basically. Well, you're right, Dr. Sami, right? You will check for estradiol levels, LH levels. But as I said, I mean, all clinics have different protocols. So if you only had a few scans, then that's the clinic protocol that they use, which is fine. I mean, we all are different, so yeah. So another question for Karen: are segmentals considered viable, and can a result be labeled aneuploid IE +9 and also mosaic qualities?
Okay, that's an interesting question. So one about segmentals. If it's associated with mosaicism, so it's a segmental aneuploidy, but there are also in that sample that we've analysed euploid cells, then segmentals can be considered for transfer. And there's lots and lots of reasons behind that, but essentially that's we can consider it with genetic counselling. So in terms of a segmental, right the way through the sample, so we have the sample and it's a segmental aneuploidy all the way through, i.e. no mosaicism, there's no euploid cells. There is some work at the moment within certain clinics and for some labs in the UK that are looking into that. So at the moment it's too early to say whether they're considered to be viable. But in terms of mosaicism, yes. Can a result be labelled aneuploid, i.e. +9, and with mosaic qualities? Well, +9, if it is mosaic, the report would tell you that it's +9, and some of the cells have +9 aneuploidy and the rest are euploid. So it depends how they report that. But you can see, we see some interesting results coming from PGT-A where we have a complete chromosome 9, extra copy of chromosome 9, and then we might have another chromosome that is in a mosaic form. So it can be, they can be sometimes quite tricky to interpret. But I think that's the answer to that particular question.
Yes, thank you, Karen. We have Dakota. She's asking if you can explain a little bit about trisomy 15.
Trisomy 15.
Yes, please.
Yeah. Well, if we saw trisomy 15 in a PGT-A result, we wouldn't transfer trisomy 15. If we saw that in a mosaic result, then we might consider it, with caveat that there could be a correction. And again, it comes into the nuances now, what we could expect to see with a trisomy 15, whether we get a rescue event and it becomes 2 copies of 15. There's some nuances associated with that particular chromosome. So yeah, if we saw it in the PGT-A, we would be suggesting no transfer.
Perfect. Thank you, Karen. So for Dr. Sami, I was told that I have fluid accumulated in my fallopian tubes and that's affecting my implantation. Does it need to be sorted before having IVF?
So yes, what this lady is talking about is something called hydrosalpinx or hydrosalpinges if it's both tubes. And this means that there is some fluid, as she says, inside the fallopian tube. The fallopian tube, normally on ultrasound, we can't see it. It's very thin structure which is collapsed together, and you can't see it on ultrasound normally unless there's something inside it like the fluid. But the problem is this fluid usually is as a result of inflammation, most typically for infection. A past infection doesn't have to be STDs, but things like chlamydia are very common causes of hydrosalpinx, but there are many other infections that can cause this. Sometimes it can be after surgery as well, but anything that is causing fluid to collect in the tube is usually linked to inflammation, and this tube is filled with inflammatory fluid, which has a very different composition to the environment that we want inside the womb for the embryo to implant. And this fluid, if it leaks back into the uterus, will change the temperature, the pH, the osmolarity, everything will change. You know, the electrolytes. It's going to be a very different environment for that embryo, and that embryo may struggle to implant. So what we know is that for women with hydrosalpinx, especially if it's what we call communicating, if it's able to go back, the fluid is able to go back into the uterus, then this significantly reduces IVF success, at least by 50%. And definitely, in my view, it's important to have surgery to treat this. It will be usually a laparoscopy, which is a keyhole surgery. It's not a very big operation, but if you have had previous surgeries, it may be more risky. So we have to balance that as well with the benefits. But usually in most cases, it's quite a straightforward procedure. And the best treatment is actually to remove the whole tube, which is so shocking for some women to hear because they don't want to really to have something to remove the whole tube. But that tube is now damaged. It's not going to be helping them to get pregnant naturally. It's going to have high risk of ectopic if they get pregnant naturally. And therefore, the removal of the tube is actually the best way to improve the IVF success rates. And therefore, that's what we recommend. Now, in certain situations, it's difficult to remove the tube, especially if a woman's had previous operations. And in that situation, what can be done is they can put a metal clip, usually, right at the edge of the tube where it meets the uterus, and that will block any fluid leaking back into the uterus and block this problem. And that's another solution. It's not quite as good because sometimes that clip can slip off a little bit, or there can be a little bit of leaking from the side, but it's kind of the next best thing if it's difficult or risky to remove the tube completely. But certainly that would be the best treatment for someone who has definitely got this hydrosalpinx, is to get the tube removed.
Thank you, Dr. Sami. The next question is, do you have an upper age cutoff for IVF/testing?
Well, yes. I mean, unfortunately, as a woman gets older, IVF becomes less successful. And especially as we get towards the mid-40s and beyond, then IVF is very rarely successful, is the sad reality. And it's something that we face a lot nowadays because many women are delaying conception. They're not getting pregnant anymore in their 20s, and they're often waiting till 30s or sometimes even 40s or even mid-40s before they even think about starting a family. And then they are shocked to hear that actually, even with the best technology, with the best treatments, we aren't really giving them a good chance to have a conception with their own eggs. So with regards to this question specifically, I mean, I would prefer to do IVF up to the age of 46, I would say, is the cutoff. I've seen a handful of women at 46 get pregnant over 15, 16 years, not many. So the success rates are kind of 1% or less. But if someone really wants to try, then we can give them a shot. I've not seen anyone above 46 get pregnant with IVF. I know it still isn't impossible, but it's a really, really small chance. So in general, I don't recommend it beyond that age with own egg treatment. The way around it sometimes that people choose to go for an egg donor, which isn't for everyone, but if that's what they are choosing to do, then with egg donation, we can treat them up to the age of 50, because after the age of 50, the risks of pregnancy itself on the woman is going to be quite high. So definitely it's better to try and get pregnant earlier. It will be easier, cheaper, safer. So that's kind of the education that we need to get out to women, because I'm not sure that everybody's heard that message.
Thank you, Doctor. We cannot share the slides, but this webinar will be available on our social media and our YouTube channel. So you will be able to, rewatch it if you need it. Okay. Dr. Sami, Vanessa is asking, well, she's saying that she's 42. What are her chances if she does IVF?
So success rates are very variable, of course. So we need to have the whole history, the whole picture, because for some people there are many complicated issues which may be difficult to overcome, and we may have to revise success rates. But I would say, it also depends on the clinic. So each clinic will have their own success rates, and you can look into this separately. But I would say for 42, for most clinics, you're looking at between 15 and 22, 23% chance per IVF cycle. 43 will be about 15%, 44 maybe about 5%, 45 maybe 1 to 2%, and then 46 is 1% or less. So it does drop off quite quickly, which is why, Vanessa, if you are thinking of doing IVF, it's better not to leave it too long.
Thank you, Doc. Okay, so, well, it's been almost an hour already. So, Karen, would you like to share some final thoughts for this webinar today, please?
Yeah, I think, really, PGT-A isn't for everyone. I think we've managed to get that message across, but it can be considered. It's if somebody is on a very long journey and for their IVF treatment, and they're really wanting to give the best shot, then it's possible if they've got, as Dr. Sami said, a good ovarian reserve, and they've had recurrent miscarriage, it may help. But really to think very, very carefully, and age does come into it. And it depends where. So it's about the journey. It's about age, but it is possible, and it can actually help some people. Can you hear me?
Yes, we can.
I got cut out. Oh, sorry. Yeah, I think that's, it's not easy. It's hard.
Thank you, Karen. So I would just also like to say, yes, definitely, I agree with Karen. PGT-A is not for everyone. Now, it's quite interesting to see how in different countries PGT-A is regarded in different ways. So, for example, if you go to the US or in the Caribbean, where me and Vivian have worked as well before, it's actually very common, and perhaps even majority of cases will be PGT-A. And in some clinics in the US, I know from a personal colleague of mine who works there, they only do PGT-A. So if you don't do PGT-A, you don't do IVF, basically. And even if you have one embryo, whatever, of your age, whatever, PGT-A is kind of their requirement for doing IVF cycles. And then there are other countries, Germany, for example, and there are other places where, Belgium, I think as well, where PGT-A is banned. It's not allowed, it's illegal. And in the UK, thankfully, we aren't either extreme. We have, the option to do PGT-A, and it's not for everyone. It's something to discuss, to think about. I think it is a personal choice as well. The patient should make an informed choice about it. But webinars like this will help you to understand it and know the pros and cons, and whether this is something that you would like to pursue or not. Because PGT-A is not without its drawbacks. It's not kind of the thing that will definitely give you a success. You could transfer PGT-A embryo and not get pregnant, and sometimes the results can be confusing, and sometimes you can get an embryo which we throw away because it was labeled wrong or whatever. So it does have its drawbacks, and that's certainly something to think about.
Correct. Well, thank you very much, Dr. Sami, Karen, for all the ones who joined. We truly appreciate your time and expertise. And for all the ones who are interested in having an appointment with Dr. Sami, you can always check our webpage at planyourbaby.co.uk. We are on social media as well. And if you want any counseling session with Karen as well, please contact us and we will refer you. And thank you for your time, for all you who joined from Plan Your Baby, Karen, and all who attended. Thank you very much, and enjoy the rest of your evening.